I said dinner is over and it's time for desserts. But when this case comes to PG student in the exam, he or she is completely at sixes and sevens in trying to answer these questions. Most of us don't even know if it's a kyphosis or a scoliosis, and you'd rather have hope that you got a lumbar canal stenosis as your long case. But trust me that the symbol of orthopedics is a scoliotic tree, and Ortho Pedos means straight child, so it refers to scoliosis. So I'm making my case to say that the good news is it's the easiest case. It's a great long case to have. It's a gold medal case if you ask me. The second good news is that I'm sharing this presentation with all of you on WhatsApp and all other places, so you can casually rummage through what I'm talking about. To get to the point, scoliosis has been defined by the Scoliosis Research Society as a lateral curvature of the spine of more than 10 degrees. And as surgeons, you will see scoliosis as this. So it's famously seen as the hunchback of Notre Dame. But in truth, it's actually a three-dimensional deformity. It's not a single plane curve, but it's actually a curve in three planes. One is what you see front on or on the coronal plane, which is a C-shaped curve. On the side view, you see a hypokyphosis. So unlike a common perception, it is actually a flat back or a reduction in kyphosis. So typically a scoliosis, which is an adolescent idiopathic scoliosis, the lordoscoliosis rather than a kyphoscoliosis. Must remember that. And in fact, it is actually a rotational deformity. So all of you will do well to imagine a scoliosis as a stack of carom coins that have been twisted up in the middle, and that twisting has led to the spine, to bend over in multiple planes. How does this spine bend? So to clear this confusion, you should look at this diagram at the bottom right. Always remember the vertebral body shifts towards the convexity, and along with it pushes the rib out, and hence the rib hump and the rotation of the vertebral body is on the side of the convexity, while the spinous process points to the side of the concavity. How do you determine whether this is a true kyphosis or a true lordosis? Run your thumb along the spinous processes, and you'll see that the furrow is quite deep. The spinous processes don't pout out. Some definitions that you need to know: a structural curve versus a non-structural curve. A curve that has a lot of intrinsic changes, like the bone is rotated or the bone is wedged, or a curve that does not straighten up on bending is a structural curve, while the other is a non-structural curve. Another definition is major and minor curve. This is an English language definition. A curve that is larger is always the major curve, and the one that's smaller is always a minor curve. And hence, you guessed it right. If there are two equal curves, it's called a double major curve. What about compensatory curve? So when the child bends, there's another part of the back which is a flexible structure which tries to balance this bend, and that curve which is trying to balance the center of gravity, that's called the compensatory curve. A fractional curve is a curve which is only 1/4 a circle, while a full curve or a regular curve is one that's at least half the curve. These are quite colloquial definitions. This is important. What is decompensation? So a scoliosis that takes the head outside the line of gravity is a one that is a decompensated scoliosis. So if you drop a plumb line, you need to carry a plumb line to your examination room when you go for the exams. It's just a thread with a weight hanging at the bottom to aid gravity. So if you put the top of the thread on the vertebra prominence and drop the plumb line down, if it's beyond the natal cleft by more than a couple of centimeters, this is a decompensated curve, which is bad news because gravity alone will increase this curve. Typically, AIS increases with growth. But if it's a decompensated curve where the center of gravity is shifted, even after growth stops, this will keep on progressing. Quickly to tell you about what these confusing names are, because you will be asked this in the exam. Strategic vertebrae are vertebrae that actually make the deformity. So when you look at the Indian cricket team, there's a whole bunch of guys there, but your eyes only look for these big guys, right? So similarly, they're big guys in a curve, and these are the end vertebrae, apical vertebrae, stable vertebrae, and the neutral vertebra. So the end vertebra, this definition you must know, it is a maximally tilted vertebra on either end of the curve, as you can see in this pictorial. So each curve in a spine, every spine has 3 curves. So this spine has a curve on the top, a main curve here, and a curve at the bottom. So make a habit of looking at every spine divided into 3 parts, and you'll start seeing those 3 curves. So every curve has an upper and a lower end vertebra. The lower end vertebra of one curve could coincide with the upper end vertebra of the other curve. So in a spine, you could have a maximum of 6 end vertebrae and a minimum of 1, 2, 3, 4 end vertebrae. I hope that's clear. To identify end vertebrae, you look at which bone is most tilted. Like here, you can see the L1 seems to be most tilted. But if there's any doubt in your mind, draw lines that are along the end plate, and you will see that these lines diverge into the convexity of the curve. So if these lines turn parallel, it means that these two bones are equally tilted, which means the L1 would be the end vertebra. And in fact, if the lines converge towards the convexity of the curve in question, you've gone into the next curve. So in a situation like this, the L1 would be the lower end vertebra of the main thoracic curve. I hope that is very clear. When you do bending x-rays, these end vertebrae change. However, end vertebra for a given curve is like the name. Your name will not change whether you're in Bombay, Delhi, or North America. Similarly, once end vertebrae are defined on a standing AP x-ray, you cannot change that name. And hence, end vertebrae on a bending x-ray are called intermediate vertebrae. These are important to know because these are the bones between which the segment of the scoliosis is stiff. And if and when you're doing surgery for this patient, you have to work harder on this segment. What is the apical vertebra? The apex of the curve is the apical vertebra. This is invariably the most rotated, but curiously, the most horizontal vertebra, as against the end vertebrae, which are the most tilted vertebrae. Sometimes the end vertebrae could, the apical vertebra could actually be a disc. So how do you know which is the apical vertebra? You draw a line that is perpendicular to the central, draw a central sacral vertebral line, vertical line, which is a vertical drawn from the middle of the sacrum, and draw a tangent to it along the curve. And where the tangent cuts the curve is the apex. So in this particular case, it's cutting the curve at a disc rather than a bone. So in this case, the apex of this scoliosis is actually a disc and not the bone, which means that this scoliosis has two apical vertebrae. What is a neutral vertebra? End vertebra alludes to tilt. Apical vertebra alludes to apex. Neutral vertebra alludes to rotation. So a rotation of the bone is looked upon as a face of an owl. So when you look at an owl, it's got two eyes, which are the pedicles, and a nose, which is a spinous process. So when the owl is looking at you in the eye, the nose is in the middle and the eyes are equally spaced. The minute the owl starts to turn his face around, one eye looks bigger and the other eye looks smaller, and the spinous process starts looking bigger and bigger. So rotation is been defined by Moe based on the this presence of the spinous process vis-a-vis the pedicles. What about the stable zone? You may be asked, this is an engineering concept. The zone in which the line of gravity falls. So if you draw two vertical lines from the L5S1 junction, that is a stable zone. It's important if and when you do an operation to start and finish your surgery in this stable zone, else your tower will be erected outside the line of gravity and it will tend to fall off on one side. Stable vertebra is the vertebra that is best bisected by the mid-sacral line. Again, this is self-explanatory, and your lower instrumented vertebra should safely be the stable vertebra. So if you stop your surgery here, your entire tower will be erected obliquely and it will fall off. So end your fusion at the stable zone. If you do not end at the stable zone, as you can see in the diagram, the entire fusion will fall off on one side. So you should know your strategic vertebrae, because if you reach the point of an X-ray in your exam, which means you're probably getting a gold medal, you will be asked this, and this is Pakka gold, right? Now, this is the key part for a postgraduate history taking in an AIS. The specific questions that you ask in an AIS case is age, because younger the child, the more likely he's going to progress. Growth spurt, so when did the child achieve menarche or puberty? Birth history, was there a difficult labor or anything specific? Brothers and sisters who are suffering from a similar condition. When was the curve first noticed? What's the progression of the curve? Has it been rapid or has it been slow? Remember, chief complaints and the onset, duration, and progress of chief complaints. If you follow this mantra, all your cases can be dealt with. So what complaints do you ask? So a typical case of an AIS will have none of these complaints. So if your child complains of any of these, of course, back pain, everyone complains of, but anything else like weakness, numbness, significant pain, dysfunction, breathlessness, it is not AIS, remember. AIS patients only complain of cosmetic deformity. Now, that is not enough. It's not good enough to say my patient has presented to me with a cosmetic deformity. You have to specifically ask what part of the deformity bothers the patient. And when you give your final diagnosis, this should be a part of your final diagnosis. So when you look at the patient in the clinic, you look at the neck tilt. Again, this is a very useful slide. And if you can just describe all this to your examiner, rest assured he's not going to take you any further and you're going to be a pass, right? So neck tilt, trapezius fullness, shoulder height, chest deformity from the front and from the back, arm trunk distance, truncal shift, flank crease, pelvic tilt, limb length discrepancy and attitude, and neurology. If you can allude to all these points in your final diagnosis, you're mostly sorted. And these are the specific areas that you want to look for. You always examine a child of scoliosis in the sitting, standing, and lying down position, and you examine the gait. It's important because if a scoliosis disappears on sitting, it means this scoliosis is secondary to a limb length discrepancy or infrapelvic pathology. If the scoliosis retains itself on standing and sitting but goes away on lying down, it's because of a painful stimulus, which means that it's a spasmodic scoliosis. So it's important to examine these. You examine gait because hip and knee pathologies are visible in a gait when the child starts to walk. So I hope this is amply clear to everyone. When you look at a rib hump, the method to identify the rib hump is the two textbook method, where you make the child bend at about 90 degrees and look at him tangentially, look at her tangentially, put two textbooks tangentially on top and see the distance between these two. But today on your phones, there are gyrometers available, and there's a Scoli Angle Pro app, which you can use to actually calculate the angle. Of course, examine the spine range of motion and everything that your fantastic mentors have told you in the initial lectures. Which are the curves that are likely to progress? So you will be asked, what are the red flags in a scoliosis? A younger patient, a patient with a reserve sign of 0 to 2, a male patient, sorry, this says female, it's a male patient, a patient who has a family history, a Cobb angle that's higher, a rotation that's more, and double major curves are known to progress faster. What about X-rays? They will ask you, it has to be a 3-foot standing film, a 36-inch film, which is to be taken from 3 feet away. Don't miss the lateral film. So it should be an AP standing film. The most important, second most important, is a lateral film. When you look at the X-ray, you want to look at the end vertebrae. You want to calculate the Cobb angle. That's the angle between the end vertebrae. And you got to look at the riser sign, and you got to look at the rotation of your end vertebrae and your apical vertebrae. And if possible, describe your stable zone. And that should do the trick. The next X-ray that you ask for, so AP standing, lateral standing, and then supine bending X-rays. Remember, these are not standing bending X-rays. These are supine bending X-rays, which tell you about the flexibility of all three curves, not just the main curve that you see, but even the lower curve, which is important in planning. In case on an X-ray, you find that the rib is actually abutting against the ilium, you do what is called a traction film. For example, in this X-ray, you find there's a lot of space between the rib and the ilium. So here, a bending film will give you a true sense of the flexibility of the curve. But if the rib is hitching against the ilium, you do what is called a traction film, and that's more common in your kyphotic neuromuscular scoliosis, and that will tell you how the correction is. Look for pelvic obliquity, make the child lie down and examine the hip. So in your final diagnosis, all these should be covered. The cause of scoliosis, which side is the main curve convex to? Is it a single or double major? Is it compensated or not compensated? What are the likely end vertebrae? What's the likely Cobb angle? Is it kyphosis or lordosis? Is it a big or a small rib hump? Is it rigid or flexible according to you? What is the age and growth potential of the child? What is the pelvic obliquity? And point number 12, why has the child come to you? What is his complaint? What is her complaint actually? And in any of these are the classic red flags where you would suspect that this is not an idiopathic scoliosis. A younger child, a left convex curve, a male child, rapid progression in the scoliosis, skin signs, neurology, pain, or a family history. All these would make you suspect this is not idiopathic scoliosis and get an MRI scan done in all these cases. Of course, when you classify scoliosis, I'm going to skim through this because this is all there in your books. There is dystrophic scoliosis, which is typically neurofibroma. There's degenerative scoliosis. But you got to know the King's classification, and I have a simple trick to remember the King's classification. Number 1 and number 2, type 1, type 2 are T and L, double curves. Type 1, T is small, L is big. Type 2, T is big, L is small. Type 3 and type 4 are C-shaped curves. In type 3, L3 is in the midline. In type 4, L3 is outside the midline. And 5 is a double thoracic curve. So it's quite easy to remember the King's classification. It's much more difficult to remember the Lenke classification. And I beg you not to try to remember this classification. You'll forget everything else. So just remember the principles that Lenke classification teaches. It tells you that every curve is made up of 3 parts. So even though one curve is staring at you in the face, look above and look below before you decide what kind of a curve this is. So divide every spine into 3 parts. The second thing it tells you is look at the sagittal profile of every spine. Don't just be happy with the lumbar, with the AP view. And the third thing it tells you is that identify and subclassify your lumbar curve, because that's what's going to tell you how low you need to go when you do surgery. And quickly to come to management principles, of scoliosis. The idea of surgery is fusion, and the surgical limit is most cases after a 40-degree angle of Cobb's are considered surgical, but the child should want the operation. There's no need for the operation. There's a want. So if someone comes saying, I'm feeling happy with myself, you don't need to offer surgery. It's a purely cosmetic surgery in adolescent idiopathic scoliosis. Because the surgery alludes to correcting and fusing the spine, you're halting growth, and hence you want to delay surgery as much as possible till you can get maximum growth in height. The ideal age for surgery is, of course, after growth is achieved, which is about 2 years after meniarchy. But the closer you can get to this is better. 40 degrees is the cutoff for surgery, but this is not a rule that's cast in stone. There are variables. A 30-degree curve, which is decompensated, may still become surgical. They will not typically ask you indications for surgery. All that you need to know is that indication of surgery is if the child is unhappy, which is cosmesis. You don't get respiratory problems in idiopathic scoliosis. You get respiratory problems in neurofibroma, in high-grade syndromic scoliosis, and in cases which have deep kyphosis. The surgery is done by posterior instrumented correction. So you put anchors, and the methods of correction are translation. So you put anchors in the spine, screws in the spine, and pull the spine to a straight rod. As barbaric as it may sound, it works. The other is the cantilever technique, when you push the rod against the spine and correct the rod using anchors. So that's the cantilever technique. And the third is the derotation maneuver, where you put a bent rod and then twist it around in a way that the spine corrects. So a bent rod is then twisted to make it look straight, and that makes the spine straight and makes the spine nicely curved on the side view. And that's the kind of correction you get at the end of the day. So finally, to sum up, when you make your diagnosis, you say which type of a curve it is: left, right, convex, thoracolumbar, lumbar. You say whether it's compensated or decompensated. You ideally talk of the end and neutral vertebrae. You talk of whether it's kyphotic or lordotic. You talk of rotation and rib hump. You talk of flexibility to the in your final diagnosis. You talk of the remaining growth potential. Sum up the pelvis and the hips, and finally make your diagnosis with all these 11 points. The point number 12 being, and sir, this patient has come to me with the chief complaint of a rib hump that irritates the patient. So my take-home message is, identify your scoliosis well, give your diagnosis in the 12 parts, and get a gold medal. Thank you.